We are just done with the bradyarrhythmias. Now let's see about the tachyarrhythmias. The tachyarrhythmias are mainly of two types, the supraventricular and the ventricular. First, let's see the supraventricular tachyarrhythmias, and the first one is atrial fibrillation. Atrial fibrillation, tachyarrhythmia, as the name suggests, we know that the heartbeat is going to be high. So the patient has palpitations, tachycardia, and chest pain, and the patient will have dyspnea, diminished exertional capacity, and occasionally syncope. This is because the heart is pumping so fast, but the cardiac output is not given properly. The heart is just trying to run, but it is not producing enough amount of blood. This atrial fibrillation can cause clots and can lead to thromboembolism, commonly seen in stroke patients, that is the cardioembolic stroke. There will be atrial fibrillation, then there will be formation of clots, and that clots would be dislodged and go and block in the circle of Willis or anywhere in the cerebral circulation, causing stroke. That is the cardioembolic stroke. And this atrial fibrillation is the most common arrhythmia. If you see the ECG findings, there will be a heart rate of more than 300. The rhythm is irregular, and the P waves are absent, and the QRS is narrow. The treatment for these patients are beta blockers or calcium channel blockers to decrease the heart rate. Previously we saw that in the bradyarrhythmias, the patients would be using beta blockers or calcium channel blockers for any other reason, and they would develop a decrease in heart rate causing bradyarrhythmia. But now these patients having tachyarrhythmia, we are giving beta blockers or calcium channel blockers therapeutically to decrease the heart rate. And when the patient is very unstable, we can give a DC shock. Then, since these patients have thromboembolism, we also are required to give the anticoagulants. If you see the ECG paper about the atrial fibrillation, you can calculate the heart rate that is more than 300. And how to calculate the heart rate? Everything I have explained in the ECG physiology video. You can kindly check it there. And the rhythm is irregularly irregular. Now what does it mean, irregularly irregular? If the rhythm is regularly irregular, that means there is some abnormality in the rhythm, but that abnormality has a proper fashion. For example, it will be like one R wave and two boxes empty, then again one R wave, then one box empty, then one R wave. Then again this pattern would repeat, one R wave, two boxes empty, one R wave and the other R wave. This is regularly regular. But if irregularly irregular, there is a problem or abnormality in the ECG, but that abnormality does not have a regular orderly fashion. It will be just haphazardly arranged, irregularly irregular. And the P waves are absent here, as you can see. And the QRS is narrow. Most of the supraventricular tachyarrhythmias would have narrow QRS. Then if next one is atrial flutter. And the next one we are going to talk about is the atrial flutter. Now, after seeing the atrial fibrillation, what is this atrial flutter? In the atrial flutter, we can see the patient again having the same symptoms, and the patient can also produce thromboembolism in this. The ECG findings are more than 250 beats per minute. The rhythm can be variable, that it can be regular or irregular. There is a characteristic finding, that is the sawtooth pattern in atrial flutter. Now the QRS is narrow here, as I said, for all the supraventricular tachyarrhythmias. The treatment here is again to give beta blockers or calcium channel blockers, and if the patient is unstable, the patient would require a DC shock. The ECG findings in atrial flutter, if you see the heart rate is more than 250, the rhythm can be regular or irregular, and there is this characteristic sawtooth pattern, and again the QRS is narrow. Then next the multifocal atrial tachycardia. These patients usually will have a history of lung disease like COPD. So if a question says a COPD patient is developing an arrhythmia, you should first think about this one. The patient's ECG findings would be heart rate of 100 to 150, and the rhythm is irregular rhythm. The P waves is present but has different morphologies. If you see here the P waves and this P waves, there is a difference in the morphology. And see this P wave, they are different in the shapes and sizes, that is different morphology. The QRS is narrow. Here an important thing to be noted is the isoelectric line is maintained. As we saw in the atrial flutter, there was a sawtooth pattern, so there was no isoelectric line, but here the isoelectric line is maintained in multifocal atrial tachycardia. The treatment here is calcium channel blockers, preferably verapamil, to decrease the heart rate. DC shock is not useful here, as mainly we have to treat the underlying causes, that is for underlying causes like COPD. The amiodarone can also be used here. This is an antiarrhythmic drug.